I'm Deborah from Henpicked Menopause in the Workplace. And today the subject of our interview with is how to get the help and support you need during menopause from your GP. And I'm delighted to welcome again Kathy Abernethy. Now, obviously your credentials are as long as this half-hour session, Kathy, but past chair of the British Menopause Society, extensive clinical experience, and the director of menopause for Peppy. So welcome.
Thank you very much, Deborah.
And we were talking beforehand around where people who are joining this call might be coming from. And I know that at the end of this session, what we really would like to get to is removing any hurdles that anybody might have. Because we know when we're doing training sessions with employees in workplaces, that there's those who are thinking about going to see their GP, those that have been to see their GP and haven't got the help and support that they wanted, and maybe even those that are kind of already in the system, but their HRT, for example, isn't quite right for them. So it's worthwhile us focusing on those that are perhaps thinking about going to see their GP first. I know we're seeing a very worrying trend that's keeping me awake at night, actually, from women saying, I'll wait until COVID's over before I go and talk to my GP about my menopause. So can you sort of help us understand why we don't need to wait?
Thank you. Yes, certainly I hear this too. And it does put my back up a little bit, actually, because, you know, you could have a very long wait if you wait for COVID to be over and for the NHS to be back to normal. And all GPs now are saying that they're back to service. They're offering different types of appointments. They might be offering telephone appointments. They might be offering remote Zoom type consultations. It's quite likely that you won't get a face-to-face appointment for menopause. That's true. But that doesn't mean that it all has to go on hold. And actually, it's a really good time while we're thinking about our health, thinking about COVID, to be looking after our health from a menopause point of view as well. So I would really encourage women to really take the bite now and to get help for their menopause. First of all, it's important for women to get help now through COVID. Don't just put it off. The sooner you get help, the sooner you'll start to feel well again. And secondly, GPs want you to go. They don't want you to sit there not getting the help that you could have. They want you to actually reach out and to get the appointment, which might be telephone, yes, which is less than ideal, but still do go ahead.
Yes, I often think that it's that we don't prioritise ourselves. We may be looking after everybody else, but we should be giving ourselves more priority. But sometimes it comes down to a misunderstanding around diagnosis of menopause, thinking women have to have blood tests or blood pressure tests before they can be diagnosed. Can you just cover how menopause is diagnosed so that we're all really clear on that?
Yes, it's interesting that lots of us think we need a blood test because we're used to blood tests for other medical conditions. But actually for menopause, we listen, as a clinician, I listen to your story, I listen to the symptoms that you're experiencing, and I put together the pieces of the jigsaw really to build up a whole picture of whether this is menopause. And if one of the bits is missing because maybe you're not the classic menopause age, then yes, a blood test might be necessary. But for most women, when you tell me what you're feeling like, you tell me what's happening with your periods, you tell me how old you are, it's very easy for me to put together that jigsaw and say to you, yes, that's the menopause.
That's the menopause. So no need to wait for blood tests. And actually the guidance says that over the age of 45, for a woman who is otherwise presenting healthily, a blood test is not required.
That's absolutely true because it's going to be so unreliable. As we go through the perimenopausal changes, the hormone tests that you might think that you could measure are actually fluctuating really, really widely. So it could actually be doing yourself an injustice if you get a blood test because it could be very difficult to interpret. And what happens sometimes is that you end up with a blood test which neither confirms nor denies that you're in menopause, but actually your body is telling you full well you're in menopause. So blood tests over the 45 are not needed, and that's particularly important around COVID time when you don't want to be having unnecessary blood tests.
The other one we've heard, Kathy, is you need to have a blood pressure test before the doctor can confirm. Is that, and of course you can't necessarily get into the surgery. What's the guidance on that?
This is really interesting, Deborah, because this has changed through the COVID situation. 6 months ago, it would have been absolutely routine to have a blood pressure check before you had your HRT and once you were established on it. But actually, it was always being done as a well woman check rather than to check your HRT. So it was a good thing to have done because it's important to pick up high blood pressure. But actually, the HRT that you take isn't going to affect your blood pressure. So now that we can't do blood pressures, those of us in menopause clinics are resigned to the fact that we may not be able to do that well woman blood pressure check, but we can definitely still prescribe HRT. So the recommendations that have come out from our professional bodies has reflected that, to say that we can still prescribe HRT even without a blood pressure measurement, as long as, of course, your blood pressure is normally good. If you're somebody whose blood pressure has been high in the past, then it is possible that your doctor will want you to have a blood pressure check first.
Thank you. So don't wait, but you can also help yourself during this time by doing the prep, because this comes down to really good communication, doesn't it? I mean, whether it's in the practice or whether it's on the phone or online. I know you're doing a lot of online consultations. It's good to do the preparation beforehand, because you've usually only got 10 minutes. So we recommend that people keep a list of those symptoms, understand any changes in their bodies, so that the conversation with the GP can be, this is what I'm experiencing, this is how it's affecting me. Do some reading beforehand so that you have an idea what sort of your philosophy might be, what help you might want from your GP, and then ask for your GP's view on everything that you've said based on your medical history. Do you find that works for you?
Absolutely. And the one thing I would also add to that is right at the beginning of the consultation, be quite clear in your own mind and also with your GP as to what the purpose of the consultation is. So it's very easy for the GP to be sidetracked into maybe talking about risk when actually all you wanted to do was to get a diagnosis and find out whether you were in menopause. So I would say that the opening sentence really should be the reason that you want the consultation. So for example, you might say, I've come to see you today, or I'm talking to you today because I'd like to start HRT. That's your number one reason. And he knows straight away, or she knows straight away. But equally, it might be, actually, I'm not looking for HRT, but I would like some reassurance as to whether this is menopause or whether I have something else wrong with me. And then you'll guide the conversation down the right direction right from the start, and you get the best use out of your few minutes that you get with your practitioner.
While you're on the subject of HRT, Kathy, because this is one that we hear a lot about, the risk and benefits, and I know that there's a video of you talking about the risk and benefits on henpick.net, but that's often one that puts women off, isn't it? That they think HRT is a lot riskier than it is.
Yes, I mean, the whole HRT risk picture has been built up over the last 20 years when there was a very important US study which showed that there may have been some association with breast cancer risk. Over the last 20 years, though, that study has been re-evaluated. It's good data, but it perhaps was exaggerated and misapplied. So what we have to do is move away from thinking about the risk of that big mega study and actually start asking the question, what's my risk as an individual? So if I take HRT, what's my risk? And if you're low risk generally, if you're healthy and you're menopausal and you're taking HRT to relieve symptoms, then actually for most women, the breast cancer risk is very small. There may be a small risk. We take risks all the time, don't we, doing different things, but we measure the risk. So every time we get on a bus or when we can, an aeroplane, we take a calculated risk. With HRT, the risks are very small and the benefit is much greater. So it's finding out for you what the benefits will be, get rid of your symptoms, make you feel better, protect your bones, protect your cardiovascular system, perhaps improve your memory, function, things like that. And the risk may be similar to having a glass of wine a day or being overweight. That's the context of risk with breast cancer.
Thank you very much. So hopefully that's removed some of the hurdles and encouraged some people to go to see their GP. Or have a consultation with their GP if they've been putting it off. What options does somebody have? Because we still hear it, and I would say we hear of so many GPs that are absolute superstars. But what about what can women do if they go to their GP and they don't get the help and support?
It's such a shame that menopause has become a bit of a subjective subject rather than an objective. So if you go with any other medical condition, you will be told what your options are and what to do about it. Whereas menopause, doctors, not just doctors, all healthcare professionals seem to have their own opinion about it. It's become a very moral debate. And I think we need to move away from that. So I would suggest that if that's the direction your doctor is going down, then perhaps see a different GP within the same surgery. And what my hint is to always speak to the receptionist, because they know very well which doctor is open to discussions about the menopause. So I would broach it then. You've got the right GP who's got the open mind and the knowledge, and you're more likely to get what you want from it.
It's interesting that you say about, because that's one of our top recommendations, always ask the receptionist who in this practice has specialist interest in menopause. And very often we'll find some women will say, I'll wait and see a female GP. But actually, if I think of my local practice, the best person I've seen there was a young male locum who was absolutely phenomenal. And at the end of the session, I said to him, I actually wasn't going for my menopause, but he said, while you're here, I noticed that you're, mentioned my age, and he said, and I thought, yes, fine. And I said, is there a problem? Is there everything okay? Thinking he'd got some test results. It was actually my acne that I was going for. And he said, I just wondered if anybody's talked to you about menopause. I was completely blown away. So, and I said, that's really interesting. Are you interested? He said, I think every woman over 45 that comes into a GP surgery should be offered a conversation. So, we shouldn't be fixed in our own minds. And of course, Mr. Nick Panay is a wonderful consultant. So, we need to be thinking about who's got the specialist interest rather than what age and sex they are.
Absolutely, yes, I'm with you there. And it's the doctors, the GPs or the nurse practitioners in the practice who have done courses and kept up to date and who have the knowledge which is evidence-based now in line with NICE guidance. That's the one that you want to see, and that's going to be the one who's had the interest to actually go ahead and look at all that.
Fabulous. So if you're my doctor and I don't get what I want from you, what's my course of action?
I think to step away and accept that that particular GP is not the one for you to see, and go to the receptionist and say, I'd like to see somebody different. And if you really don't get any joy from any of them, it's often worth writing a letter to the practice manager just saying, this has been my disappointment of an experience, but could you direct me to the doctor who can help me now? And that means, again, that hopefully you'll be directed to the GP that actually has a special interest in it.
Fabulous. And if you're, because we know that some cases will be more complicated, we often have women saying to us, oh, I can't have HRT because the doctor said my great aunt had breast cancer and he doesn't want to do anything about it. There is an option to be referred if you're a special case, isn't there?
There is, yes, you're right. The NICE guidance says that if you've got a true contraindication to HRT, so if you genuinely can't take it, although the lady that you just described probably could take HRT, but if you have a true contraindication, then nobody should just be told, oh, sorry, you can't have it. They should have the opportunity to talk to somebody who works in a specialist clinic like I do, because we work beyond the NICE guidance sometimes, which is easier for us to do than it is for GPs. And we will treat each person as an individual and weigh up the risk and balance for them. So sometimes there are options available in a specialist clinic that your GP can't offer quite reasonably.
The other one, Kathy, would be that, because that's if you don't get what you want from your GP. But last time you were with us, you said, oh, there's over 70 preparations. It can be more tailored than people realise. But we had a woman explaining to us that she's on her second preparation. It's not quite doing it for her, but she's kind of been told it's that or nothing.
That's such a shame, because actually my experience is that lots of women have to try 2 or 3 actually before they find the one that finally suits them, even if it's just a tweak in dose. I mean, it may be a complete change of HRT, but sometimes even just tweaking the dose. So if I, as a menopause practitioner, prescribed an HRT and the first one was perfect, I would be astonished, because it just doesn't happen. Most women do need a tweak, do need a change. And that's what you're going back for your 3-month follow-up for, and then your 6-month follow-up or another 3 months. So if you're meeting that resistance, yes, I can't promise you the perfect HRT, but there are other options. There are things to try. So do your research and think about, do I just need a dose change? Maybe I just need a bit more, or actually do I need to start again and try a different HRT?
Well, that's the lack of understanding around how many different preparations there are, isn't it? Because we will often have women saying, I tried it once and it didn't really work for me. And we know that it started at a lower dose and built up over a period of time. So, some people fall off HRT that way because it doesn't really have the impact that they expected. And it could well be that, as you say, the dosage just isn't at the right sort of level.
Yes, it could easily be the doses of the estrogen may be too low or even too high for some ladies. You may have to come down a dose. Or it could be the progestogen. The progestogen comes in different types and different groups of progestogens. And very often one type of progestogen will suit somebody and the other won't. It's not necessarily that one is better, but if you're on one and it's not agreeing with you, the other one might. So it's often worth changing to different types. And if you're going to change HRT, you do want to be sure that you're changing in a way which makes sense. You don't want to just change from one brand to another brand, which is almost identical. So that's why you need somebody to actually look at what you're on and make an intelligent switch.
Yes, and the final thing on the different sorts of HRT. Sometimes we have feedback that my GP said that until I've stopped my periods, I can't have HRT.
Yeah, that's one of the biggest myths around menopause, isn't it? That you can't start treatment until actually you don't need it anymore. When you most need the treatment is often when you're still seeing periods, because there's a group of women in whom the menopause symptoms are at its worst before they actually stop. And then when the periods stop, they start to feel better again. Other ladies, it's the other way around and they're fine. And then when their periods stop, they start to get symptoms. But if you're in the former category and you've got symptoms, it doesn't matter that you're still having periods. That's the menopause or the perimenopause, and that's the time to start your treatment.
Absolutely. And just give us because I know every time we have you with us, we always say, how's HRT supply doing?
Well, today I've got brilliant news, because actually almost every HRT is now in stock, almost every, which is really good news. There are some postcode variations. So before I get shot down with ladies telling me they can't get it, there is general availability around the UK, but there are regions where it's a little bit more tricky. And the good news is that 85% of patches are now back in stock. Unfortunately, the one that's not back in stock is Estradot, which is the nicest patch of all. That's not yet fully available, but will be soon, I'm told. So the picture is looking much prettier than it has been, Deborah.
Fabulous. Thank you very much, Kathy. And I'll invite my colleague, Sally, to join us, because I can see that there's various questions and chats going on. Hello, Sally.
Hello. So we've got some good questions coming in. So I think the timing of when you can start HRT was definitely one of the things that came up, which is great that you've answered that. But it's what to do if your GP says you can only take HRT for a certain amount of time, so you should wait till things get really bad before you start it, because otherwise you're going to have to stop it before you need to. There's this whole thing around the length of time you can take HRT.
I think the time to start HRT is when your symptoms are particularly bothersome. So that may be quite early in your perimenopause, or it might be quite late. That's when to start it. I wouldn't suggest that people need to worry about when they're going to stop, because some women will only need HRT for a short time, and those that need it longer can safely take it longer. So to say to that GP, I would just say, well, okay, let me start it now if I've got my symptoms now, and then when we need to talk about coming off it, we'll talk about that then, bearing in mind that the British Menopause Society guidance is that there should be no arbitrary length of time that you're on HRT. So it should be individualised. So don't put off taking it just because of that.
Yeah, and I think that comes up time and time again in sessions that we run,
certainly.
where they're giving this, you know, yeah, well, you can have it, but you can only have it for a year, or you can only have it for 5 years, or whatever it may be, and there's that arbitrary, as you say, time scale put on it. The next one someone asked is whether a GP can advise on non-HRT treatment. So if HRT wasn't a choice a woman wanted to take, or wasn't an option because for them it wasn't a possibility, would a GP be able to advise on other approaches to managing their symptoms?
Yes, I think GPs can certainly manage symptoms without HRT if you've got a medical reason not to use HRT. So that's certainly an option. It becomes a bit trickier if you're looking for herbal and supplement recommendations, because GPs are taught very firmly to only recommend things that have a strong evidence base. And we know that some of the supplements and dietary things that you might do will have an effect, but you can't say that they have a strong evidence base. So GPs will pull back a little bit from recommending them. But NICE guidance is quite clear that things like black cohosh, red clover do have a degree of evidence. So the GP should at least discuss that with you.
Yeah, excellent. Okay, I'm just going to go through and just see. Yes, we've had someone, they're asking whether if they're really not getting what they want from their GP, is it worth exploring going to seek kind of private medical support, and what the options are around that, because they were saying that they don't feel they're getting that support and help from their GP.
I think it's a shame if you end up having to go private just because you're not getting the support from your GP. I mean, it's different if you're wanting to get quicker support, or you're in the position of being able to afford to pay somebody privately. I think the first thing to do is to see if there's another GP in the practice, or maybe the nurse practitioner is often the person as well to see. But if you do decide to go and see somebody privately, I would recommend that you check the British Menopause Society register of specialists to see that they meet the criteria as a menopause specialist, if that's what you're paying to go and see. And also just be a little bit aware that there is a big difference between what some specialists are prescribing, conventional bioidentical HRT, and some using the compounded, which is not supported by the British Menopause Society.
Yeah, that's brilliant advice, excellent. And the final one that I've got here is just around if somebody's on the mini pill and they're struggling with symptoms, whether they'd be able to go straight from the mini pill onto HRT. Do they need to come off one and go on the how that works kind of in combination with each other?
Yes, if you're on the mini pill, so that's a progesterone only pill rather than a combined oral contraceptive pill, so that's using only the hormone progesterone as a contraception, then you don't need to stop that when you go on HRT. You can use them both side by side, so you've still got your ongoing contraception, but then you can take HRT as well.
Thank you. May I ask the follow-on to that one, Sally, because one of the questions is around my original GP retired after diagnosing me with perimenopause. The new one is making me go through the same process that I've already been through, including trying birth control, a Mirena coil that my body expelled first time, now progesterone, that was the other one. Mirena coil is an interesting one, isn't it? Because a lot of women will ask the question, do I have to have my Mirena coil taken out to see where I am on the journey before I can start HRT?
Yes, and actually this goes hand in hand, as you say, with the last question, because the progesterone-only pills, or the mini pills, and the Mirena, neither of those will mask your menopause symptoms. So you will still get your flushes and sweats and symptoms if you're on those. The only thing it will mask is your periods. So you might be fortunate and not be getting any bleeding on them, but believe me, your menopause is going on behind and you'll still have the symptoms. So you don't need to stop one in order to see what's happening through your menopause journey.
It is tricky for some women though, isn't it, around when do I stop taking birth control and move on to HRT?
Yes, so the rules generally are that if you're not on HRT, you can stop your contraception when you've not seen a period for a year if you're over 50, or 2 years if you're under. If you go on HRT while you're seeing periods, you won't know when you hit that marker. You won't know the stage that you're becoming menopausal. So most women who then make the transition onto HRT continue using contraception alongside it, either as a Mirena or as a mini pill, or using condoms, barrier methods as well. In which case it's usually recommended that you stay on it until about the age of 55. After 55, you're not likely to get pregnant.
Thank you very much. And I guess if there is to be a benefit in COVID, it is that you can have consultations with experts anywhere in the UK. You could have Kathy Abernethy sitting in your living room, or the leading experts in the UK on the other end of the phone. So that's a benefit in some ways, as you say, if you want to go private. But also, one of the things that is starting to be introduced into some organisations is Peppy. And now, personally, I wish Peppy would offer the service to individuals, but some employers are now recruiting Peppy to do menopause consultations for their employees.
Yeah, so Peppy, which I'm delighted to be working with, is working with employers to offer individual personalised advice. So it is for individuals, but you access it through your place of work. So it's paid for through your place of work, and departments and organisations recognise the importance of this for women at this stage in life. And so they offer it as a benefit to their staff. So what you get from Peppy is access to a practitioner like me, but on a one-on-one basis. So everything you want to know about your menopause and your support is accessed through your employer, but individually and confidentially with somebody like me, a menopause practitioner.
And it's great to see so many employers now considering that as an essential part of menopause support, because I'm thinking here, if anybody's fortunate enough, but I know I was on a call with Santander, and you support Santander. So employers are starting to appreciate that giving extra support in the workplace, whether that's getting everybody talking about it, so it's not a hushed thing. It's as easy to talk about menopause as it is the weather, or for that matter, that Peppy is sitting there in the reward and recognition scheme. It's always worth checking to see if your employer has those services too.
Absolutely, and if they don't, I'll suggest it to them, because it's been so appreciated. And Santander, as you mentioned, is a really good example. The people that have signed up for Peppy through Santander have really appreciated it, not only on an individual level, but actually for their employer as well. They feel quite good about their employer because it's being offered to them as an individual support service.
Thank you very much, Kathy. And do we have any other questions at all, Sally?
Just got a final couple. Just one around, given that HRT offers protection for bones and cardiovascular risk, can it be started even with no symptoms present?
So it could be. I think you'd need to you just need to ask, what are the benefits for you as an individual? And yes, you'll get the cardiovascular benefits and the bone benefits, but it's not a sidestep from doing the other things that you also need to do. So it's not a question as if I take HRT, it will take care of my heart and my bones and I don't need to do anything else. So you still need to do your weight loss or your weight management, your exercise, looking after your diet. You still need to do all of that. HRT is just an extra bonus, if you like, for women who need it for their symptoms. They're getting this extra bonus for their health. Whether you take it if you don't have symptoms at the normal age, I would say depends a bit on your risk. So you take into account your family history, whether other people have had osteoporosis, and how high a chance it is that that's in your family, then it may well be worth taking it. Yeah.
Okay. Fantastic. We've just got one final question then, around somebody who's struggling with menopause, and she has severe endometriosis, and so her GP's uncomfortable prescribing HRT, and so has referred her to an endo clinic, but there's a huge wait to be able to see someone. She's been struggling with horrible symptoms for 6 years, and just wondering any advice on the best approach to get some kind of response and some support on how to manage menopause, HRT, endometriosis, and who you would advise her trying to get to see.
Yeah, so there's two issues here. One of the other advantages of COVID, which Deborah alluded to earlier, is that actually the whole referral system within the NHS has now changed, and you shouldn't necessarily have to wait the months that there is for appointment, because we now have what's called advice and guidance. So in this instance, you could ask your GP to fast track this through the new advice and guidance system, which means that they get a letter back from the consultant without you having to actually see the consultant. So that's a good thing. But on an individual level, if your periods appear to have stopped and the endometriosis is settled down, then I think you could take HRT and talk about HRT with your GP. So I think that's worth pursuing as well.
Fantastic. Thank you very much.
Thank you very much, Kathy. So we'll put the notes together, and it'd be great to get that link from you where we could find out more information about the latest guidelines, so that people can print it off and read through it and prepare to go to see their doctor. But as always, it's an absolute pleasure, and thank you very much everyone for joining us. We look forward to seeing you again.
Thank you very much. Bye-bye.